had to look for ways of dealing with my hot flashes. I experimented. Is it a placebo effect, or is it really helping me?
It's hot off the press. Cognitive behavioral therapy is actually listed as the top non-hormonal option.
That caught my attention too. These are hard things for women to get. At the end of the day, we want women to feel better.
Yeah, not Houdini on Amazon. We're talking clinical. Whatever beautiful means to you, this time of the month will help you find it and live it. Welcome back to This Time of the Month. Today, we are back with Teresa Isabel Dias, our menopause certified pharmacist, and we're going to talk about hot flashes or vasomotor symptoms of menopause. I just want to thank everyone for watching our podcast. Don't forget to like, share, and subscribe. So, Teresa, welcome back.
Hello, thanks for having me.
So, it is important to talk about menopause hormone therapy. I know we've talked about it previously in other episodes with Dr. Jessica Green, but the topic will never go away. And I think it's because the fear will outlive the new evidence. So what's your take on it? Walk us through it.
Hormone therapy?
Yeah.
It is the most effective treatment for vasomotor symptoms, which are hot flashes and night sweats, for healthy women under the age of 60 or within 10 years of the last menstrual period. But because there's still so much information online regarding the adverse effects and regarding the risks that were never perfectly explained to us, the fear subsists in women and in healthcare providers alike.
It makes you wish that we could timestamp internet or news headlines so that when someone finds
archive, new information.
Data.
Yes, it would be great.
It's really too bad, especially there is very much a fear, of course, of cancer, and dispelling that fear is going to take a long time. So there is, with respect to menopause hormone therapy, we'll call it MHT for the rest of the episode, an obsession, it seems to me, with the term bioidentical hormones. And since you are a pharmacist, explain to us.
So MHT is the new term for HRT because we're not replacing hormones. We're just adding some to improve symptoms, to make a person's life better. So bioidentical hormone therapy bioidenticals was, first of all, a marketing term. So you brought up the fear of hormone therapy. We know it started with the results of the WHI trial in 2002. I was working in a pharmacy in mid-Toronto at the time, and one of my patients literally threw her bottle of estrogen pills down the toilet, which you never do that because you don't want medication ending up in the water supply. But she did that. She came back to me 2 days later, pulling her head off and feeling really, really distressed because all her hot flashes, night sweats, the symptoms came back with a vengeance, and I had nothing to offer. We were told it's bad, it causes strokes and heart attacks and increases the risk of breast cancer. And now what? Nothing to replace what was used previously. So many people with great business ideas filled in the gaps.
Sorry, I'm going to stop you there. Because of that WHI study, you are saying it got not just patients throwing it down, but off the shelf, so to speak.
Yes, pretty much.
Yeah.
No doctor was prescribing hormone therapy, and women who were taking it came to me. Many, as I said, stopped taking it. One went down the toilet, and a few asked, I don't want to take this anymore because it's dangerous for me. What do I take instead? And I had no answers. It was a very frustrating and sad time to be a pharmacist because your hands were literally tied. I don't have anything for you. So
the gap got filled.
So the gap got filled by bioidenticals. It's not a hormone. It's not bad for you. It's natural. It's plant-based. It won't cause breast cancer. It won't kill you of a heart attack. Take it. And of course, if you're not sleeping for a few weeks, if you have all those bothersome symptoms again, And you hear something that like this, and you forget that if it sounds too good to be true, it probably is. You're going to take whatever because you need
You're
help.
desperate. Yeah.
So that was how the bioidentical world started. Because so many people are still using bioidenticals, because again, we have an archive does bad things. Societies like North American Menopause Society, Endocrinology, American Society, they had to take a stance, and instead of hiding under the rug, they had to come up and say, okay, this is a problem. Women are taking this. What can we do to improve the safety of the products and the safety and the health of women? So after many years of back and forth, they decided that they considered bioidentical a product that is structurally, chemically similar to a hormone we produce. So in pre-menopause, we produce 17-beta estradiol. After menopause, we don't. So now there are products that you can use orally and transdermically that are made with 17-beta estradiol. In the second phase of our menstrual cycles, we also produce progesterone. And they are part of a family called progestogens that include progestins and progesterone. Progestins are chemically made synthetic products, but progesterone can also be made, and it's chemically, structurally similar to the one we produce. They are not what we produce, but they are similar in structure. And there are no natural hormones that occur in the world except in us.
Yes.
So whatever hormones are in the products, they have to go through labs and being chemically adapted to be what they are and incorporated in the products we buy. So there's no such a thing as you pick a petal of a flower and you eat a whole basket of it and you'll have a natural hormone. No.
Thank you for dispelling that. I like to think of the Health Canada and FDA approved menopause hormone therapies as body identical.
I like that
I really
term
like
better.
that term. Yeah. So is there, speaking of hormones, we focus a lot, estrogen, progesterone. What about the role of testosterone? Members of my community have asked, and I mean, testosterone is not a male hormone. We produce it too. What's the role of testosterone?
So the predominant female hormone is estrogen. The predominant male hormone is testosterone. They have very small amounts of estrogen, and we have small amounts of testosterone. And both in men and in women, the testosterone levels decrease slowly with age. In women, the estrogen levels decrease very abruptly during the menopause transition, but the testosterone decreases after, some say, age of 30, it starts going down. So we lose testosterone with age, and it has nothing to do with a menopause transition.
All right. And it does, though, appear there's chatter.
Lots of it.
Lots of chatter on testosterone for libido.
Yes.
Where's the evidence on that?
There isn't. So first of all, there's no testosterone approved in any country except Australia, I believe, that is dosed for women. So in Canada and in the United States, if you use a testosterone product, is marketed, has been approved to treat men with low testosterone levels, there's no dosing, there's no product for women. So that's a caveat. How much are you going to give a woman? Because we are not just a man with boobs. We are very, very different. So there's a few studies, as I said, not as many as we would like, and there's no approved products for females. Then what is it good for? Not for everyone. And we have to be very careful who should use it. Because like everything else, it has adverse effects and it has health risks. So sexual dysfunction is not directly related to low levels of testosterone. So if you think that you're not having the sex life you had before or the desire or whatever. It may not be because your testosterone is low. It may be for a whole bunch of other factors, because you have vaginal dryness and sex hurts, therefore you avoid sex. Maybe because you don't have a good relationship with your partner. Maybe psychosocial cultural reason and not testosterone per se. So we have to be careful in diagnosing sexual dysfunction and assuming that it's always a testosterone problem. But there are women that have been diagnosed with HSDD, hyperactive sexual disorder or dysfunction, which is the lack of desire that bothers you. If you have lack of desire and it doesn't bother you, you're not going to be diagnosed with HSDD. But if it bothers you that you no longer have a desire for sexual activity, or you don't react well to it, it's a complex diagnosis, but you can be diagnosed with HSDD. And there are studies that show that testosterone for these women may be positive, may be effective.
So let's hope there's more studies. One of my big pet peeves is the lack of studies regarding women's health issues in general, but obviously anything pertaining to midlife, as we are here on the Teton Couch. So let's hope we see more evidence. So as of now, not enough evidence.
No good formulations to use. There's a risk that by using what we recommend 1/10 of a man's dose, it's still too much. There are no good tests to tell you how much testosterone is actually in your body. And there are serious adverse effects and risks of taking too much testosterone.
You saying the test word brings up a really interesting question. I have a lot of people tell me, I went and had my hormones tested in my saliva, or by other means, but the saliva one I find interesting. What's the validity there? Should our audience, be looking to test their hormones in perimenopause and menopause, and under what circumstance?
So I'm not an expert in tests, but what I hear from the societies is that testing in saliva is not accurate, and testing as a means of diagnosing menopause is not necessary. We don't treat menopause symptoms based on your levels of estrogen, for example. And the machines that we have these days and still now are not very good at measuring very small amounts of estrogen. So it's not an accurate measurement of how much estrogen is in a person's body, because we know we have a lot more in premenopause than we have around the menopause transition, and we'll have even less in postmenopause. It doesn't matter, because the outcome, the treatment, is not going to be affected by how much estrogen you have. It's going to be based, or should be based, in how you're feeling. Are you having hot flashes, night sweats? That is the reason why you procure estrogen therapy, and not because you have this much estrogen instead of that much.
Great explanation. One fear that I have also heard from some Teton community members is the fear of weight gain on MHT. What's the evidence on that?
It depends. Some women put on weight. When you get your first prescription for birth control, it tells you that it's common for a person to increase the weight by 2 to 5 pounds, 1 to 2.5 kilos, for example. Well, the same thing could happen with the hormones. Estrogen may cause you to retain more water, more weight. So you don't know until you actually try.
One thing I liked about Dr. Green's episode is it's not a tattoo. So it's not...
It's not going to be there forever. You can adapt. You can take the hormones. You don't like it, you try a different kind. Maybe you tried it orally and didn't work. You can try transdermal. Maybe you tried one molecule, try another one. It is such individualized treatment. And it's not a one size fits all. And usually it's not the first size you try that is going to be perfect. You have to have an open mind to a transition through your treatment. It may not be the first fit the first thing that you try. But there's other things to try. So that's one of the things. Don't give up if the first treatment you experiment with doesn't work. But also don't have your expectations in check, because by adding estrogen to your life at 55 because you're having awful hot flashes and you can't sleep with night sweats, it's not going to make you feel 30 again.
Those are wise words. One of the things that we suffer and struggle with, or at least I do, that's part of the journey of TTOM, is how we view ourselves through midlife, and estrogen's not going to fix that. So hopefully these conversations with other women will help us see that there's the beauty and the power and all of those things in aging. And one of the things I like to do is, you're a professional pharmacist, but you went through perimenopause yourself. You want to tell us a little bit about your experience?
So, full disclosure, I did not take hormone therapy. It was in my toolbox in case I couldn't sleep, because as long as I sleep, I can function more or less. But I had problems with my breasts since I was 18. I had a biopsy done. I was told not to take birth control pills. I was told not to take any hormones because that would increase my risk of breast cancer. So it would be the last tool I would get out of the box. I had tons of hot flashes, but I only had a few night sweats. So as I said, I would take the sheets, the blankets on and off, and I would be able to go back to sleep after a hot flash. I never soaked through any clothes, thank goodness. So I was able to continue functioning, and it didn't affect my quality of life. It embarrassed me many times being all red and flushed, but I was still able to live my life. So I had to look for ways of dealing with my hot flashes other than by using hormone therapy. So I experimented with fermented soy, which was coming up to the market at that time. I didn't want to go to anything else but that. And if that wouldn't work, I would try something else. So it worked for me, even though we see from the experts that there's no evidence that is very helpful. I'm still one person, not a whole study group. And as a scientist, I experimented. Is it a placebo effect, or is it really helping me? So once in a while, I would stop taking it. And sure enough, 3 days later, my hot flashes were a lot more bothersome. Another thing I wish I had known earlier was about this little book, Cognitive Behavioral Therapy for Hot Flashes and Night Sweats, something like that, written by Professor Myra Hunter and a psychologist, Melanie Smith, from the UK. It didn't decrease my hot flashes, but it made me tolerate them and not be bothered by them a great deal.
That is a perfect segue. This episode is going to air after the North American Menopause Society position statement, but as we are recording it, it just came off. It's hot off the press, and I have my notes and my highlights here, and I know you do too. It's very exciting to see progress. So cognitive behavioral therapy is actually listed as the top recommended non-hormonal option. Why don't we talk about the NAMS 2023 position statement for non-hormonal options?
So it follows the previous one. It was 8 years old now, so it was from 2015. And they had, pardon me, they have a group of panelists who looked at studies and evidence data for the last 8 years to see if anything had changed from the previous position statement. And things have changed. And of course, science is always evolving and new studies come out. So we don't change our minds about things. We just know more about what's effective or not effective, safe or not safe. So now there's a new position statement, and practitioners like me and people like you can talk with some comfort about, okay, this seems to work for symptoms of menopause for those women who can't or wish not to take hormone therapy.
So the top ones here listed: CBT, hypnosis. Interesting.
Yes, very interesting. That caught my attention too.
Clinical hypnosis.
These are hard things for women to get, though,
because
they're not offered. They're not offered widely. You might have a hard time finding someone who's can do hypnosis for hot flashes.
Yeah, not Houdini on Amazon. We're talking clinical hypnosis, okay?
Exactly, and they may, for the most part, I would suspect they're not covered by public insurance and whatnot. So it's nice to see that they are helpful. But again, like I read a little book on cognitive behavior therapy. With an investment of $25, you can read the book and maybe it helps you too. But it would be nice to have more practitioners offering this type of treatment.
I feel like we need all our experts to come back on a panel discussion and basically try to convince our public health to offer
I know
more of these services.
We do.
You mentioned to me prior to the episode that you wanted to focus on a few specific treatments that are not recommended in this new position statement.
So let me take it back a step here so we are clear about therapies.
Yeah.
You know, placebo effect. Do you want to explain what a placebo effect is?
Placebo effect is basically our mind convincing us that something works in a simple manner.
Exactly.
That's what placebo effect, and it's real.
It is real, and in menopause can go up to 66% according to this new position statement. So if I'm taking something and I think it's helping me cope with my hot flashes and my menopause symptoms, it may not be because it's an effective product, it may be because it's a placebo effect. What I tell my patients and my clients is, if it's safe for everything else, if it does not have adverse effects or you don't have any contraindications to the product, and you can afford it and you want to spend the money on it and it makes you feel better, even if it is placebo effect, by all means. Because at the end of the day, we want women to feel better through the menopause transition.
Is there, what would be the, again, we always like to do takeaways. So the takeaway on the non-hormone therapies for our audience, what would they be for you?
I like to support, because they are untreated and underdiagnosed, the breast cancer survivors. Most of them don't know that there are non-hormonal therapies that are effective for hot flashes, for example. So breast cancer survivors watching this, take note that you can have some therapies that are not contraindicated for you. If you don't want to use hormone therapy, check with your doctor what non-hormone therapies like the SSRIs and SNRIs. And we didn't touch on gabapentin, which is very good for nighttime sweats. So night sweats are treated in many women with gabapentin.
Any major downsides to gabapentin?
Yes, lots of drowsiness.
Drowsiness.
So they recommend that you take it 3 times a day. Most of my patients cannot afford that because they're so drowsy they can't work, they can't live. But for some women, even a small dose at bedtime allows them to reduce the number of night sweats, allows them not to soak through their pajamas and have a better life next day. So yes, three takeaways. Breast cancer survivors have options of treatment for vasomotor symptoms. If you want to try herbals for your VMS because you're afraid due to bad information of hormone therapy, you may be wasting a lot of money and a lot of time. So think carefully about the tools in your toolbox. Maybe you want to consider non-hormonal therapies, but maybe you are a good candidate for hormone therapy and you don't know it yet. So get educated, get informed. The third one is, each of us is different. What does not work for you may work for me. So be careful when your neighbor or your sister tells you, take this because it's good for you. Always ask your pharmacist, your doctor for advice, counseling on over-the-counter products.
And there is hope. We forgot to mention some really exciting research in the pipeline and one new approved drug in the US for now, FDA approved. But our hot flashes, we are learning more. They're controlled by our brain. And so one drug, fezolinetant, you want to mention that one? We forgot about that one.
Here we are with a brand new baby on the block.
Hot off the press.
God knows if it'll ever be approved in Canada, because a lot of medications available in the States never got approved here yet, or whatever. But you have audience from all over the North American. So in the States, there's a new drug. As you said, our thermostat apparently lives up here, and we have hot flashes because our brain thinks that we are cold, and so it makes us heat up. But we weren't cold in the first place, so now we overheated, kind of thing. It's a very simplistic explanation. So they have been studying and testing medications that act on this thermostat regulator, temperature regulator, and there's a new approved neurokinin B receptor antagonist that seems to quiet down this place that makes you hot or makes you create heat to avoid vasomotor symptoms. So it's promising. It's non-hormonal. It's new. We'll see what the post-market results are. I'm always iffy about recommending something fresh off the market because we learn a lot by watching what happens in post-market.
We'll keep our research eyes on that one, but at least there is new research coming out on what modulates
which
our
is
hot
a
flashes.
whole different area of study.
And there's
that
other receptors that they're researching.
So it's good to know that people are finally looking into this because a lot of us are suffering and need help.
Because we're speaking up and we're demanding more
support.
So I've already asked you in the past about what makes you feel beautiful. So for today, we're going to do something a little different. I'm going to ask you some this or that questions.
Oh.
Okay. Star Trek or Star Wars?
None. I'm not into that kind of stuff.
Chocolate or vanilla?
Unfortunately, well, if the chocolate is pure cacao, chocolate for sure. If it's a chocolate bar, unfortunately, I'm sensitive to it and I get headaches, so I can't eat it.
Ocean or mountains? You are a big traveler.
Ocean.
Yes.
Ocean, ocean, ocean.
Well, it's always a pleasure having you on our couch, and we definitely hope you'll come back. Thank you, Teresa.
Thank you. It was a pleasure.
Now it's time for a little real talk. As we get older, our vision declines. At least for me, that's what's happening, and I must admit I'm in denial about it. I do need readers. This is a pair that I often wear. You see it on the show. It's higher end. I love it. It feels stylish, and obviously I can read with them. But I get bored. I'm also brain fog. I lose them, so I end up having to have pairs everywhere. Every room, in the car, in my... To do that, obviously you want to go for something that's feels stylish but doesn't break the bank. So I love peepers. You can get them at Whole Foods or directly online, but you know, they're super practical and I don't care if they get a little bit banged up because I always forget to put them back in their case. And for me, it's helping diminish the denial and embrace beauty and power in aging.